Well, welcome to another episode, if we can call it an episode, of Joe Reagan Conversation. And Joe, I am jazzed. I am really jazzed right now because you're not going to believe what happened tonight. Jeff Crank voted to cut Medicaid, increase the debt ceiling by $4 trillion, and a super rich tax cut of $4.5 billion or $1 trillion, excuse me. I mean, I watched it on C-SPAN, and only one Republican, Congressman Massey from Kentucky, voted against this because he said, we can't raise the debt ceiling. Come on, guys, get a grip. So Jeff Crank just flunked his first test for the constituents of the Congressional 5th District of Colorado. So, what are your thoughts, Joe, since this is a conversation?
Where do I start? I guess I start with not surprised. I mean, this is exactly what Republicans have talked about for a long time, cutting benefits, and without recognizing the why. And so let me start by to address. I don't know if we have. I would assume that most of the folks that are listening are Democrats, but let's assume for a second. And if you are a Democrat, I want you to listen to how I talk about this, because I think this is even more important. Over half the federal budget goes to Medicare, Medicaid, and Social Security. So by definition, to achieve anything closely resembling a balanced budget, there have to be reforms made to Medicare, Medicaid. Social Security, you really can't touch. There's really not much you can do there. It's the way the program is structured. There's really no way you can adjust that. So it comes down to Medicare, Medicaid. And if the GOP were really serious about reforming Medicare, Medicaid, then they would try and spend the time to understand what are the issues influencing or impacting those people that are on Medicare, Medicaid. And I think we've talked about this before, because one of the things that I've done in the private sector is actually worked on a pilot program to address something called social determinants of health. And social determinants of health are non-medical components of your life that impact your overall health care. And those things can include the amount of money that you make, where you live, your diet, your social surroundings, people that are around you. All of these things can impact how much you spend on healthcare. And private insurers, and actually to some extent the VA, have recognized the fact that when you make an investment in the social determinants of health, you can actually reduce the cost that an individual is spending on healthcare at a lesser cost. So we're not cutting, we're achieving better health outcomes for a lesser cost by addressing the social determinants of health. A great example. So one of the things that they're talking about doing is putting the work requirement onto Medicaid. Why would an individual, and we've dealt with this on a lot of different issues. The reason that individuals really can't work is usually because of a lack of childcare or the cost of childcare. And I use my sister as an example. My sister is a teacher by trade, so an educated professional, and she when my nephew was born, she and her husband had to make the decision as to whether or not she would go back to work. And the cost of childcare exceeded the amount that she was making in salary as a teacher. And so the very real fiscal decision that her family had to make was simply, it was more cost effective for her to stay home and be a mother. Now, if you are economically savvy, you should look at that and say, now in this case, they're not going on benefits. My brother-in-law makes a very good salary, and so financially speaking, they were able to operate off of just his salary. But there's a lost cost there, there's lost profit there, essentially, or lost productivity. You have a college-educated woman, someone that's contributing to a very important, well-in-demand profession, teaching, that is now no longer in the workforce because the cost to participate in the workforce exceeds what she's actually making by participating. Now, if you're a single parent, obviously that no longer becomes an option. You still have to, either you have to pay childcare, which could be a majority of your salary, or you choose not to work because you can't afford the childcare, but might be able to operate off of some other limited form of a social safety net. None of these are good options. But so, for example, if we were to increase access to childcare or find ways to reduce the cost or increase access, then you would enable those people to go to work. They would have that you would reduce the economic incentive for them, or really reduce the economic cost of them working. And that's really what we're talking about here. This is not people that are lazy that don't want to work. This is you've made the cost of working so high, it's not worth it to work because they're spending all their money to work. and like I said, this is the example that I'm citing here is a teacher's salary. So a professional, someone that's making a good wage. So if we were really serious about adding work requirements onto these types of programs, you've got to be able to make investments in other areas. And actually, you don't even need to make the work requirement if you provide the tools to enable that person to work. And that is, like you said, it's investing in childcare programs to make sure that people have. Now, does that mean, what does that look like in practice? There's a lot of different ways that we could do it. And another area that we run into a lot of, and we talk about this locally, and I don't want to bleed too much into housing, but housing is a great example here in Colorado Springs in the 5th District, because we actually have adequate housing stock for low-income housing. Low-income housing is really not a challenge within El Paso County. Middle-income housing, however, is the issue. So if someone is coming into our community and making a salary somewhere around $60,000 to $80,000 a year, starting salary, this is a young family that's coming into Colorado Springs, perhaps it's someone that grew up here in Colorado Springs and wants to stay here, that housing stock doesn't really exist. So if you're making $60,000 to $80,000 a year, there's not a lot of housing stock available for those middle-income individuals. And in the healthcare, going back to the healthcare space, we've talked about this with the Affordable Care Act, which was the benefits cliff. So on programs like Medicare, Medicaid, where you have a means test, an income test associated with it, it was essentially if you could make up to a certain level, and once you made more, you lost all benefits. Now there's a huge economic cost there again, right? So assuming that you're spending probably 10 to 12% of your income on health insurance or healthcare, then if that's being supplemented and being paid full through a government subsidy, and then suddenly you max out and you cross that boundary and now making just slightly more, if it's like $1 more than, 120% of the poverty rate, then all of a sudden you now have to pay an additional 12% on healthcare. And so what the Affordable Care Act attempted to do was to build that sliding scale of subsidies so that we really would avoid that drop-off cliff. When we think about these social welfare programs, these social safety nets, that's an important component of this, is making sure that we have that sliding scale so that, again, you're removing the economic incentive. If I make $1 more than 120% of the poverty rate, I'm not going to lose all access to benefits. That means I stay in the workforce, I continue to work, I can continue to make income and get raises, and don't have to worry about suddenly just losing all access to all benefits. That helps not only the individual, but it also helps employers as well. You're keeping those employees in the workforce. You allow them to be rewarded for the work that they're doing. And ultimately, especially for small businesses, if you're working for a small business of under 10 people that you're not required to provide benefits under the Affordable Care Act, you're also continuing to support that as well. So getting back to my social determinants of health piece, if we were to bring a program like that into Medicare, Medicaid, and I know we talk Medicaid, of course, is what we're talking. People are less sympathetic to Medicaid, but in both populations, these are folks that are disproportionately impacted by these social determinants of health. And an example that I've used in the past, and so when we were doing this pilot program, this program was implemented across the state of New Hampshire. And if I remember correctly, the total cost of the program was maybe $500,000. So this was not an expensive program by any means. One patient. Let's step back a second. In the insurance realm, actuaries look at all of us and assign a number to us. And that's why they ask, how old are you? Do you smoke? Do you do this? And those answers to your questions help the actuary determine how much do we think this person is going to spend on healthcare. And so, for example, as a relatively healthy 43-year-old man, you would not expect me to be spending that much on healthcare. Now, if I start to exceed that number, the insurance company starts to wonder. They say, why is this person spending so much on healthcare? By all means, they should be perfectly fine. And what that would do is that would cue us in this pilot to then go out to that individual, connect with them, and see what was happening. $500,000 program. We go out and there is an individual that is spending way more on healthcare than they should. They're billing the health insurer for that, for all. The health insurer is essentially paying for this. And this is why, again, another side note, I'm going on many tangents here, but this is why when we talk about the payer side of these things, who's paying for the bill, it's not really going to address the underlying cost. In order to, if we're really serious about getting and achieving universal health care, it goes well beyond who is paying, who is writing that check. Because the harsh reality, and people don't like to hear this, but we actually do have universal health care in this country. It's not good, but at the end of the day, if you look at the definition of universal health care, if you show up to a hospital, you will be treated. Period. Somebody has to pay for that. Sometimes it's Medicaid. Sometimes the hospital is paying out of pocket for themselves, but they are required by law to do that. That cost, and I've done this. I've run programs before that provide services to private insurers, Medicare, Medicaid, and someone that can show up with no insurance at all. And really what happens is you build your pricing model to assume that level of risk. So essentially, as a private payer, you're paying roughly 110 to 120% of cost because private insurance will pay it. Medicare, Medicaid by law can only pay 75 to 85% of cost. And that is, the intent there was to drive down costs through capitalism. But what it really did was cause an over-consolidation in the market. So this is why you see these giant healthcare conglomerates building up. This is why you see a decline in rural hospitals and private practice providers in rural communities. Because under these rules of reducing the amount of reimbursement that Medicare, Medicaid can provide, the only way you can do it is the Amazon model. It's got to be high volume. And the only people that can achieve that are the major health corporations. So to go back to my example, patient, way more in healthcare. Social worker goes out, talks to them. They live in a rural community. They can't pay their power bill. Easy enough. Why does that impact your healthcare? Well, they're a diabetic. And when the power goes out, the refrigerator stops working. And when the refrigerator stops working, the insulin supply goes bad. And when the insulin supply goes bad, the patient is no longer able to manage their diabetes. And then they go into diabetic shock. And because they live in a rural community, the way you get that individual to a hospital, level 1 trauma facility, is via medevac, helicopter. And so one instance of being unable to pay a $35 electric bill results in $1 million healthcare expenditure. And so we're able to go in and we see this and say, this could happen again, right? If you can't pay the power bill routinely, this is going to be an issue. Now, pretty much every power company in the country has some sort of program that if you are a low-income individual, they will work with you so the power doesn't get cut off. This is not a new expense. These are funded programs. So the social worker goes in, connects them with the program. Now the power will not be shut off again. So now the insulin supply won't go bad again. Then we take time to educate this individual on some dietary practices, how best to manage their diabetes, and suddenly no diabetic shock, no helicopter ride to level 1 trauma. And so we've alleviated that by addressing a very, very small cost, $35 for the power bill. Now we're saving literally $1 million on this individual because we're able to address a root cause, a non-medical cause for a medical cost. So bring that into the Medicare, Medicaid population. And you can see that you can start making small investments into these things and substantially reducing the cost that we're paying out through Medicare, Medicaid, and achieving better health outcomes for those individuals. That's just smart practice. And I think that that's something that if Republicans were really serious about this, and if like I said, if you're a Republican, please listen to this, because I think this is a fiscally conservative discussion of making a small investment for a high return and reducing cost. Now, if you're a Democrat, same thing, right? The idea is we want people to be healthy. We want people to be able to thrive. And we can actually do that for a lot less money when we think through the economics of why are we actually spending this much money? Why are some people stuck in this rut of having to pay so much? And that can be everything from, like I said, power bills, food deserts, food insecurity. These are all pieces that fall into that. And so if we can make those small investments early on in these social determinants of health, we see less cost on the other end. So it's that trade-off. And it's complex economics, but conceptually, I think most people can wrap their head around that, right? If I can get you to eat broccoli instead of McDonald's, well, there's a benefit to that. Because if I eat McDonald's every day because it's there, it's available, it's what's in my neighborhood, well, we've all seen Super Size Me. It doesn't end well. But if I can get you access to fresh fruits and vegetables, whether it's through a school lunch program, whether it's through, through food banks, whatever, that small investment making those health changes can have a huge impact in someone's overall health at a less cost to all of us. And a great example, and this has happened in the past. If you look back, I think it was in the 1970s in West Virginia, they were having an obesity crisis, which has continued. But policymakers kind of looked at this and said, what is one thing that we could do that might help us reduce obesity in our communities? And what they identified was, back in the 70s, most people drank whole milk. And so they said, well, that is a substantial source of fat in these people's diets. Can we convince them to switch to 2%? Which, if I remember correctly, I think would actually reduce their fat intake by about 50%. And so they did a big marketing campaign, which was measurable, of the people that switched from whole milk to 2% milk. And then you could see the decline in obesity over a period of time. Now, again, this is a causation does not always, or correlation does not equal causation. But, we could look back at those numbers and say, well, yeah, if that's the only thing that really changed, then yeah, maybe that is what it is. And so these are examples of, if we're really serious about looking at mental health, community health, we have to think beyond just treating disease, but really transitioning over into a treating of wellness. And now, if we go back, because we're in Colorado Springs, we can't go without saying the national security impact of this, right? If you have children who are not fit, they are not able to join the military. So you are depleting the pool of individuals that can join the military, which, again, for my Democrat friends, remember that the United States military is one of the greatest, largest, most effective social elevators that we have in our country. Anyone can join the U.S. military, and because of the job and the benefits and all that you have, you can pull yourself out of whatever situation you are in and find opportunity through whether you serve your 20 years or maybe you get out and take advantage of some of those benefits, like the GI Bill, like a VA loan. These are all things that you can now do that allow you to move beyond the social status that you grew up in. So that's, I guess, if I were to create an alternative to say, hey, Republicans, we agree with you. We need to be spending less on healthcare, but you can't cut the program. You got to look smart about it. And that's the difference is, Republicans are going in and they're just slashing and burning everything. When in reality, let's stop for a second. Let's think about what's causing and driving costs and address that. And I want to pivot for a second, and I'll go back to you. I know I've been now talking for a solid, 10 minutes probably, but this was another one I brought up the other day. People like to point to most of Western Europe has some form of socialized medicine, and they pay a whole lot less than we do. What they don't do is the profit margin for medical supply. And I'm not talking pharma. Pharma is part of this, but even medical device companies don't get a profit when they're selling to the European markets, which I know some of you would sit there, well, they should be profiteering off healthcare. Okay, we can make that argument. But at the end of the day, when I'm talking about profit margin, though, part of that profit margin is going to research and development. And so what's happening here in the United States is we're paying more because the only developed market that pays a profit is the United States. And so we are effectively subsidizing the entire healthcare global R&D market. Now, so again, to my Republican friends, you'd say, you know what? I kind of agree with your problem statement, but the way you're going about it is all wrong. Donald Trump has pulled out of the World Health Organization, which I think is the wrong way to go with that for a number of reasons. But think of, could we create, if Donald Trump were an effective negotiator, if Donald Trump were an effective statesman, which he is not, then perhaps you could sit there and say, well, you know, in your first term, you talked about how NATO allies weren't spending enough. And as much as it pains me to say this, he actually kind of convinced Germany to kick in a little bit more. He kind of got that. And then with Ukraine, the European allies did kind of pick up their contributions to NATO, which is 3% of GDP. Why not do the same thing with the World Health Organization? Say, if you have a socialized medicine system in your government, you should still be contributing a certain proportion of your GDP to healthcare R&D because the whole world benefits. And this is where I know pharma gets a bad rap, but I've worked with pharmaceutical companies and look at like Merck. Merck actually did more effort to reduce malaria in South and Central America, and they did it at a loss. They took a substantial loss at the investment that they made in combating malaria in South and Central America because it was the right thing to do. And we can talk about profiteering, and I'm not saying it doesn't exist, but I am saying that in some cases that these organizations do see the good in what they're able to do by getting medicine into the developing world. It's just, as the economic side of this goes, we also have to recognize that as the United States, because we are the free market system, we're the only ones contributing to that R&D budget. And that's why the U.S. has some of the greatest research hospitals in the world. That's why we have so many of these medical companies that are here in the United States that are pushing state-of-the-art in medical technology. We need to continue to do that. There's some really amazing things that I've worked on that are going to lead to better diagnostics, better treatment, more specific treatment. But that requires us to make those investments into those programs. And R&D in the healthcare space is expensive. And this is where patent reform kind of comes into play as well. I know I told you I was going to stop, but I'm going to keep going. Because patent reform is another one of those areas where if you're a pharmaceutical company, 1 in maybe 20 drugs is going to actually succeed. And I'm going to say, let's use their words, right? So one in maybe 20 compounds, they're going to find to be effective at treating something. And so to cover the cost of the R&D, that lost cost of every other drug that they've been working on, every other compound that they were working on that didn't succeed, that loss has to be offset by what the one successful compound is able to make. And this is why you see some of these drugs be repurposed. A great example, Viagra was not originally for ED. It was some sort of circulatory issue. Essentially, it's in blood pressure. I can't remember exactly what it is, but they repurposed it because they found out what else it could do, and that allowed them to maintain the patent on it for 8 more years. And so that's where some of these pharmaceutical companies are trying to maintain those patents on those compounds so they can continue to make money off what they call the blockbuster drugs, the blockbuster compounds. And is there an element of greed to that? Probably. But again, the economics behind it shows that what it also can be is you have to pay for R&D. That money has to come from somewhere. And until we develop a system, and that's where the FDA and other agencies within the government have those sorts of grants for those programs. But still, there's an economic component to this that we have to really think about in order to make it work. Let me pause, because you dumped a lot on me, and now I dumped a lot back on you.
I haven't even begun.
We might have to make this one a 2-week one.
Okay. All right. Now we'll have a two-way conversation. El Paso County has 147,014 Medicaid recipients. Okay. A little bit more in Colorado Springs. And of that number, 86,269 recipients are over 20 years of age, which means they vote.
Mm-hmm.
So, as far as I'm concerned, Jeff stepped in it tonight because of voting for the cuts. They're trying to get an $880 billion cut to Medicaid.
Mm-hmm.
So, how do you think that's going to impact El Paso County or the congressional fifth here that supposedly Jeff is to represent, which right now, so far, he is not?
Well, let's go with the economic impact, because
Okay.
I think the electoral impact, the two variables there would be, one, we're almost too far away from the election for these sorts of decisions to be truly relevant, which sounds weird. I know people have a long memory, but in some cases, when we look at what could all the possible votes he could have over the next 2 years, there's a lot of other things that he could do that will have a much worse impact on a much greater piece. And another thing, I guess, this would be an assumption, but of those voting individuals that are on Medicaid, how many of them voted Republican anyways? And I don't know that number. There's no way I can know that number. But I would suspect that at least I would say more than half of them probably are voting Democrat, if they even vote. Remember, young people also are not known for showing up to vote either. So electorally, they might be making the assumption that low-income individuals are less prone to show up. We know in El Paso County, Latino voters far less likely to show up, although those demographics are shifting a little bit. But generally speaking, again, the Latino population, the majority does tend to lean Democrat. So of those eligible voters that are on Medicaid, I guess your electoral gamble here is, do these people show up to vote, and would they even vote for me in the first place? And I think that's that might put that to say, this might not have the electoral impact, the direct electoral impact that one would think.
Well, I would think that if people are ticked off enough that they want to make a change because of a representative voting against their interest and not representing them, because I guesstimated out of that 86,000 people, plus Teller County thrown in there, if you had a 40,000 vote swing towards the Democratic or whoever the candidate is at that time, keep your fingers crossed, that it would basically change the complexion of the county or the congressional fifth, because for 18 years we had a congressman who did nothing other than parasite off the taxpayer. And now that he's retired, he's an official socialist because he has his lifetime income, he has his lifetime medical, and tried to get rid of him for 16 years and it didn't work. So hopefully we're lucky and things will change again. But real quick, I got Jeff's email, of what he is not doing. But he seems to be taking time to go on radio shows out of Michigan and locally. And come on, Jeff, pay attention to home here, because you're being watched. And so it's I think it's imperative that he start paying attention, because if he doesn't, with all the volatility happening today between firing federal workers and whether there should be a back on the payroll or not, and Musk screwing up, Jeff better pay attention and start staying at home. And by the way, I'm waiting for his first town hall. So,
well, let me say this. Selfishly, I hope Jeff Crank stays in Michigan, because I'm out here every day interacting with veterans, with business leaders, with community leaders, and hearing that problem right on the ground. And so go into the economic impact of cutting Medicaid in the population. And that goes to how many of those folks then become completely uninsured. And if you go and so, I know some pretty senior folks at UC Health. I understand how that business model works. If you cut Medicaid, UC Health is still going to have to treat those people that walk into the emergency room. And emergency room care is extremely expensive, right? So go back to my social determinants of health piece.
Yeah.
If you can call a primary care physician, be like, hey, I don't feel great, and you take care of it early, much less cost. You walk into that emergency department, bigger cost.
Okay.
And if you're not getting Medicaid to reimburse, then the private insurers, the rest of us, are paying, because that's how UC Health is going to have to do it to keep themselves, they are a nonprofit hospital. That doesn't mean they don't make a lot of money, but to keep those doors open, that money has to come somewhere. And if it's not coming from federal dollars, guess what? It's an additional tax on the rest of us. And that's where the argument has to be expanded beyond just those that are on Medicaid, that cutting Medicaid actually impacts all of us, because that cost will trickle down to every single individual with private insurance in this community. And that would include TRICARE.
Okay. Denver Health estimated that they would lose $1 billion.
Yep.
And they would have to go ahead and lay off people,
Yep.
close facilities. I did not get a reading on UCH or University of Colorado Health or Common Spirit.
Yep.
But I do know Common Spirit is loaded with cash on hand.
Mm-hmm.
I mean, loaded. I'm talking $15 billion cash on hand. So I don't think they're going to be hurting too bad. So, okay, Joe, we just blew through a 30-plus minute show here. I want to thank you again, and we'll put this up on Spotify and Amazon and
anywhere your podcast can be heard, we'll be there.
Anywhere where your podcast can be heard, and we appreciate it. And
even in Michigan. Well, can we put this on in Michigan too?
We can put it on in Michigan. So thank you, Joe. Until next time.
Thanks, Gary. Thanks, everybody.
Okay, bye-bye.